I was thinking about this the other day after I talked with you, Dr. Dan, that, I have great pictures for like during Whipples, and I have really great pictures during some liver resections, but I have hardly any pictures of, some of these bile duct injuries. And I was, wondering why. And then it kind of hit me that, oftentimes I get called in the middle, by the attending surgeon, to help repair these things. And it's often not the most appropriate time to say, do you mind if we take a pause for a selfie real quick here while we're fixing this complication? So I apologize that I don't have as many intraoperative pictures or things like that, but I will talk about, kind of my approach, how I think about these repairs, kind of what goes through my mind when I get a phone call of a patient in the ER or from another surgeon, sometimes intraoperatively, sometimes they're seeing the patient in their office or in the ER. At their hospital or elsewhere, and kind of how I approach these things. And so when I get called about these, that there's a concern for a bile duct injury, I would say there's three primary things that I think about and I want to know right off the bat. And the first one is the timing of the injury, and that's often going to be a big branching point of what can we do for this injury, and at what time course are we going to be able to repair it? There's a host of studies out there that look at the timing of bile duct injury repairs, and it's a little mixed data. Some of the studies show that there's not much of a difference in timing. Some of the studies show that that there can be a difference in stricture rate, and I'll get into maybe why that is. But I think knowing what the timing is, and you're going to approach it differently if you're getting called intraoperatively about this patient, is a whole different ball of wax than the patient presents to the ER post-op day 10 from a lap chole, and now they have an elevated bilirubin, and now they, appear toxic looking and in a significant amount of pain. I'm going to approach those patients very differently. So, knowing the timing is certainly the first question. Fortunately, though, it's usually the easiest question to answer. It's not a mystery of when did they have their surgery. The patient can tell you right away. The surgeon can tell you right away. So while it's an important question, I guess the glass half full is that it's also often the easiest question to answer of these things when I'm assessing the patient. The next thing I look at the patient is I want to see, do we have source control? Is there, like I just mentioned, is the patient toxic appearing at all? And, do they appear septic? And typically that will be in patients who present later. Obviously we should have great source control if this is an intraoperative consult at the time of the index operation. But, depending on the type of injury, sometimes the patient will just be significantly jaundiced. And if they have a complete transection with clips in place, they may not have a significant fluid collection. Or if it wasn't recognized and there's been leakage, and especially if the leakage has been going on for days or even a week or longer, I've gone in and I've had to, remove 2 liters of bile from a patient's abdomen before, and that happens. And that is not a patient that I'm going to do that and repair their bile duct injury at the same time. You need to control the sepsis, stabilize this patient more, because these anastomoses can sometimes be not only technically challenging, but even under the best of circumstances, they can be finicky and they can stricture down. Even if you're really happy with how it looks at the time, they can stricture down and they can fail and they can leak. And honestly, your first shot is your best shot. And so this is almost like launching a space shuttle to the moon. You want to make sure that all the conditions are perfect around that space shuttle launch. And you want to make sure that everything is as optimized as it can be, because that first shot is your best shot. And then, the final thing is I want to get a roadmap of this injury. If it's intraoperative, then I'm certainly going to do a cholangiogram, and probably multiple cholangiograms before this thing is all said and done. But if this is post-operatively, then, I list MRCP, ERCP, PTC, and a CTA, because we'll talk about vascular injuries as well. Oftentimes patients will get many patients will even have all of these studies obtained before we take them to the operating room, because, and maybe it's my personality, but I like to know what I'm getting into before I go there. I like to have a good roadmap to be able to prepare myself and prepare the patient and prepare the OR team. Everything ready, in the OR, and you're kind of a stickler about, you said it's good to be a stickler about having your equipment and everything how you need it to do the best surgery possible. And you were talking about it for, lap chole, but it's true for health. Maybe it's true for every surgery, but it's true for these surgeries too. These are repairs it's also true for. And you can prepare the staff and the patient and everyone in the room, the anesthesiologist, if you have a good roadmap here. If the patient is, septic, if the patient does not have source control, then the first surgery I'll do will often just be a washout and drain placement. And so that can oftentimes be done laparoscopically as well to, kind of minimize the morbidity, especially if I'm not going to plan to do a definitive repair at that time. I see huge fluid collection. If they have a 25 centimeter fluid collection in their abdomen and a bunch of free fluid in the pelvis, that is not something I'm going to ask our interventional radiology colleagues to take care of. That is something they need sometimes multiple drains to take care of. And so oftentimes, even if it's been a week or 2 weeks, that's not the best time to go back to surgery, but you got to do something. So you can, go back laparoscopically. You can irrigate out very well. You can suction out all these fluid collections and then leave a drain or possibly several drains right along the porta hepatis where sometimes you'll see the leaking bile, but oftentimes it'll just be so socked in there, you're just, it's just an inflammatory mess. You leave a drain, possibly a couple drains in that area. Hopefully you've been able to do it laparoscopically. If you have to do it open to get good drainage, it's better to get effective drainage than to get inferior drainage through small incisions. So you got to do the most effective surgery you can. And then you can reassess the patient. And so sometimes you may need to do that before you get your roadmap, which is why I listed it number 2. Maybe the patient is so sick, I'm not going to worry about getting the CTA of their abdomen if the patient has a white count of 25,000 and they're on pressors and I'm thinking about admitting them in the ICU. I want to get antibiotics in them. I want to fluid resuscitate them, and I want to get source control. So that's, definitely step 2 in these patients. Once we have source control, or maybe the patient doesn't present in that extreme type of a situation. Maybe they have a 5 centimeter fluid collection. It's right next to the liver, and it does look like it would be amenable to percutaneous drainage. Well, yeah, that would be something that we can again, fluid resuscitate them, start them on some antibiotics, make sure that, all their electrolytes are corrected and that they don't have any end organ damage, any, kidney dysfunction, anything like that. We want to tune them up as much as possible. And then, order an IR drain, and then start to get our roadmap as well, whether it's an MRCP, calling up GI to get an ERCP. Keep in mind, if there's a complete transection, an ERCP will not be beneficial for obtaining your roadmap, right? So, and you'll have to use alternative means, whether it's an MRCP that might give you great pictures, but not always. So, and then if there's a complete transection and you don't have a IR drain in, maybe it's a transection with clips at the bifurcation, well, then in those cases, the patient's going to be jaundiced. They have a significant biliary obstruction, and you will have to put in a percutaneous transhepatic drain in order to drain them and relieve their jaundice and relieve their biliary obstruction. And then at the same time, you get that in, and now you do a cholangiogram through the PTC, and that gives you your roadmap. That shows you, is the bifurcation intact? How far below the bifurcation, if any, do you have an intact bile duct? And guess what? If you have a very high bile duct injury where the bifurcation is not intact and there's an injury separately to the right and the left ducts, you may need to put in 2 PTCs to drain the left liver and to drain the right liver. And usually you'll drain one first, and the radiologists don't always like that second phone call. Hey, I know you did a great job with this drain. You did such a great job. We want a second drain. But it's the best thing for the patient to drain the whole liver so that they don't get significant atrophy of that, because that's what will happen is their bilirubin may go down, because if you drain even half of the liver, you can get a normal bilirubin, but you will cause inflammation and atrophy of the corresponding side of the liver that has not been drained. So you want to get 2 percutaneous drains in if there are clips and if there is a proximal obstruction that you can't access via ERCP and put a stent in. Here is the Strasbourg-Bismuth classification of injuries. Dr. Rosser did a wonderful job of going over that. This is the classification that I use primarily. And again, like I mentioned during your talk, Dr. Rosser, is I think it's easily understood. I think it encompasses the common types of injuries. I think that you can describe this accurately and effectively to patients, to other experienced hepatobiliary surgeons, to new trainees alike. And it gives you a sense of, how am I going to approach this for repair? And I think, from my standpoint, that's often I'm trying to think forward, and this helps me make those plans. Now, I am going to talk for a minute here about, kind of the general pathogenesis of the classical injury. And this image and the following image is taken from a paper written by Dr. Strasbourg, who kind of, has been one of the pioneers about describing and trying to lead efforts for the prevention of bile duct injuries. And also one of my mentors from my fellowship, Dr. Scott Helton, where they wrote this very informative paper on vasculobiliary injuries during cholecystectomy. And they spend some time to talk about, how do these injuries occur? And so typically, I don't know, can you see my arrow as I'm pointing here? So typically, bile duct injuries don't happen at number 3 right away. They happen much lower, because you're grabbing the gallbladder and you're retracting it laterally. And maybe this cystic duct is very short. Maybe you put this common bile duct on tension and you think you're right here, but in reality, you've pulled the bile duct away from the porta hepatis in the liver so much that when you think you're in the cystic triangle, you're actually behind the bile duct. And so for whatever reason, a surgeon may mistake the common bile duct for the cystic duct, and they think everything is going well and they get around it completely. All is well. If they're doing this and they're putting clips on, then I can tell you they have not gotten a critical view of safety, and that's key. And so that's the first error, but maybe they've gotten around it and they see the gallbladder narrowing down and they think to themselves, well, I'm in a hurry, or I want to get this done. And so they put some clips on it. And then normally, if you put clips on the cystic duct, well, then you start coming up along the gallbladder to take the gallbladder off of the cystic plate and the gallbladder fossa. Well, if you're here, you're going to do that same thing. And if you don't recognize that injury, then you take a low injury of the common bile duct and you keep climbing higher and higher and higher and approaching the bifurcation of the bile duct. And let me tell you, as a hepatobiliary surgeon, fixing a low bile duct injury is much better and much easier and safer for the patient and has better outcomes than fixing a high bile duct injury, especially once you start getting up into the bifurcation here. And if you do not recognize the bile duct injury, then you convert a low bile duct injury into a high bile duct injury. So you think you're taking the gallbladder off of the cystic plate and you keep going higher and higher and higher. And eventually, just to get the thing out of the abdomen, you're going to have to come across it again. So this is where Dr. Rosser was talking about surgeons describing, well, I noticed an extra tubular structure. Well, there it is right there as they're pulling away from it. That's that extra tubular structure that they saw. This isn't a barren anatomy. This is normal anatomy. They're just have an error of visualization, an error of recognition of where they're at. And then so without the recognition, unfortunately, they've turned a smaller problem into a much bigger problem. And now they've converted a low bile duct injury by climbing up along the bile duct and transecting even higher. And sometimes they'll do that and they'll notice there's a tubular structure and they'll say, oh, there's another tubular structure here. It must just be a barren anatomy. I remember reading as a resident that there can be a lot of a barren anatomy in this area. This just must be one of those cases. So they put some clips on it. Or sometimes they're just using cautery because they think that they're done. And they think that they're just taking the gallbladder off the gallbladder fossa. And as they cauterize through, they see something, leaking bile. And they say, oh, this must be a pretty big ductalushka. And let's put a clip on that. Or maybe they don't recognize it right away and that causes the bile leak. But yes, Dr. Rosser, please.
Jesse, I'm so sorry to interrupt, but this particular photograph from Strasbourg, it illustrates, and you're illustrating points. I believe, just like in trauma, notice that in trauma, you have your first scan exam, then you get your secondary exam. I believe when you go in on gallbladders, you should scan the horizon and get your anatomical power players. Now, what this shows just beautifully is that, number one, look at the 6 o'clock. That's the duodenum. You have to recognize the duodenum, and you should not be placing clips near the duodenum at all. Now, to the left of that is Rouvier's, the little Rouvier's sinus. That's Rouvier's sulcus? Yeah. That's right to the left of that picture, and you cannot go lower than that. It's right above where the number one transection is. Rouvier's sulcus is right above that. And then medially, as you described so beautifully, what happens as you're coming up and you think you have the gallbladder, guess what's right above you? The falciform ligament. So it's those 3 power players that say danger, danger, Will Robinson, all right? The duodenum, Rouvier's sulcus, and the falciform. If you're operating there, you know that's a no-fly zone. But that picture just is excellent.
I love this picture. This is a great article by Dr. Helton and Dr. Strasbourg, and this picture I think is an excellent example of how biliary injuries occur and how minor injuries or lower injuries are converted into bigger problems, higher injuries, more severe injuries. And then this paper also talks about, and I want to talk about vasculobiliary injuries. So like you mentioned earlier, Dr. Rosser, these vascular injuries can occur up to 60% of the time. And that's not surprising if you know the anatomy of this area. Where does the right hepatic artery travel? Well, the right hepatic artery travels right behind the common bile duct in the porta hepatis. And it's also not hard to imagine that if you've put yourself in a position where you've mistaken the common bile duct for what you thought was the cystic duct, well, it's also very possible that you made the same mistake and you've mistaken the right hepatic artery for what you thought was the cystic artery. And so even if you don't make a complete mistake like that, and you do identify the cystic artery accurately, just the location and the close proximity of the right hepatic artery to the bile duct. Most surgeons are used to getting completely around the gallbladder, completely around the cystic duct and cystic artery, because what's back behind there? Just, some liver bed. And there aren't major vascular structures that they could, with cautery cause thermal injury to, or with, too rough traction cause tearing or injury to. But if now all of a sudden you're not at the cystic duct and the cystic artery, but you're around the common bile duct, well, you can cause injuries much more easily, because the right hepatic artery, it's right there. And you can cause thermal injury to it. You can, when you're cutting, when you're clipping, if you're not disciplined about putting your clips only where you can see them and through the windows that you've made, and if you're just putting clips into deep tissue somewhat blindly, then yeah, you might clip the duct, but you know what? You might grab part of the cystic artery, and that might actually even injure and cause more bleeding. And then you'll put more clips in that area. And so this is something that can happen very commonly. Like I mentioned earlier, I suspect that arterial or vascular injuries happen even more commonly and are often unrecognized and undiagnosed, because the liver blood supply is so robust. You may only have a little bit of atrophy of the liver, especially if it's just a clip over a segmental branch of the artery, or maybe even over the right hepatic artery itself. The patient may have a mild elevation of their LFTs, but you know what? Most of these are done as an outpatient surgery, so we're not checking their LFTs post-op day 1, post-op day 2, and then by the time you see them in the office, their symptoms are resolved and they're doing well. So this is absolutely something that is important to, one, know it can happen. And it's important from, a biliary surgeon standpoint, because what is the blood supply to the bile duct? Well, it's the right hepatic artery. And so if we need to do a repair of a bile duct injury, and if we need to do an anastomosis to the bile duct, well, the first thing you learn as an intern in residency training is you need to have no tension and no ischemia to any anastomosis that you make. So the last thing you want is to have an unrecognized injury to the right hepatic artery, which is going to be your primary blood supply to your bile ducts, and go in right away and do an anastomosis to a relatively ischemic structure. So for those reasons, part of my roadmap is obtaining a CTA of the abdomen for nearly every single one of these patients, so that we can identify and trace out the hepatic artery structures. One, know if there's aberrant anatomy. Is there a replaced right? Is there a replaced left? But I want to know, is there ischemia to the bile duct before I go and do a repair? And if there is, that might be a reason for me to delay the repair. And and there's benefit in delaying the repair and leaving drains in and stabilizing the patient, because studies have shown that there's going to be ongoing necrosis of the bile duct that may not stabilize until 8 to 12 weeks after the injury has occurred. And you don't want to go in and try to do a repair during that time. You need to allow that period for neovascularity, and that will happen, but you need to allow that period to occur so that you can do a safe anastomosis, and an anastomosis that has the highest chance of being successful. Because like we talked about, you get your first shot is your best shot, and you don't want to necessarily rush these things. And if you know that your best shot may have to be in 8 or 12 weeks, then that would be best for the patient. I don't know if Dr. Rosser or Dr. Dan, if you have any comments about, vascular injuries or the pathogenesis of these, or if you have any questions, about that. I'll kind of talk about the principles of bile duct repair next, but I wanted to see if there was anything more that I could clarify on this.
No, just want to echo this is something that may come up on tests and practice. Going back to my days as a fellow at the Cleveland Clinic, we used to accept some of these injuries as transfers prior to handing them over to the hepatobiliary or transplant team. And the standard approach was to also make sure that you get a CTA when the patient is in interventional radiology, because that's information that you want not only from a surgical standpoint, from a strategic standpoint, but also from a medical legal standpoint, to ensure that the common hepatic, proper hepatic, right hepatic have not been injured also during the operation.
As your Dr. Rosser, anything to add?
No.
Okay. One question that also often comes up more from the patients than from anyone else is if they have, if there's a complete transection of the bile duct and they have, maybe you're able to control that with PTCs, or maybe there's complete transection and the proximal bile duct is open and those drains you put in surgically or the drains you put in through IR at the porta hepatis are basically controlling all of the bile that's being made from the patient's liver. That may be 1 liter or 2 liters of fluid a day. So it's incredibly important to counsel the patient on making sure that they replace those fluid losses. Now, certainly back, I don't want to say in the old days, but X number of years ago, there were many surgeons who would have patients, collect the bile from the drain, strain it, and then refeed it to them. And they would drink it. Or if they had an NG or an NJ tube, they would put it down. That would probably be easier to handle, putting it down the NG than drinking it. I don't think that's necessary in today's day and age. Certainly you're worried about not only the fluid losses, and you don't want the patients to get dehydrated, but they're not just losing water, they're losing electrolytes as well. But I think that, if they drink in a 1-to-1 ratio of something like a Gatorade or a Powerade, they're replacing those electrolytes in a pretty effective way. I will usually recommend that the patient start a multivitamin, and especially a multivitamin with the fat-soluble vitamins included. Or maybe if they have them, their multivitamin doesn't include that, a multivitamin that includes vitamins A, D, E, and K, because they won't have the bile to help them absorb, these fat-soluble vitamins, but they, can kind of override it a little bit by having higher dosages of those fat-soluble vitamins. So along with making sure that they're getting optimal hydration and electrolyte replacement, I think replacing their vitamins and making sure they're getting that as well, especially if this is someone who has a very complex high injury with an associated vascular injury that we may be having drains in for 8 to 12 weeks in order to control, have source control their sepsis and allow for neovascularity until we do plan a repair. As far as, what are some principles of bile duct repair? So what do I do when I actually am, repairing these injuries? Primarily, first I want to look at the area of injury. And so this is, again, important to determine, is this something that is a surgery that I'm doing at the time of the index operation where I got called into the OR, or maybe they sent them directly from their OR to my hospital where I can take them directly to the OR and repair this? Or is this something that is later? But I want to talk to the surgeon. I want to read the operative report to know how was the injury, how did it occur? And was there a lot of cautery used? Because this is something that if there was a lot of cautery, even, it seems like more and more surgeons are using the harmonic as well for laparoscopic cholecystectomies, which I'm not the biggest fan of. But if that's the case, then you can't rely on the bile duct that has had cautery on it to give you a good anastomosis that won't have necrosis occur over the next 3 to 5 days and that won't stricture down. So you oftentimes will have to cut back several millimeters, maybe even a half a centimeter, to where you have good, healthy tissue, to maybe even where you start to see the bile duct bleed. In some cases, I might want to completely avoid the area of injury. So let's go to the Stewart-Way classification, right? So if we look at a class 2 injury, and this is the same picture you put up, Dr. Rosser, if this patient is presenting to me, a week after a class 2 injury, or 2 weeks after, when they're in a maximal inflammatory type of situation, there's no way I want to start digging around in that area and start removing all of those individual clips and deal with all the inflammation in that area. I'm likely to cause more harm than good if I try to remove every single one of those clips that they put in there. In those cases, I'm going to actually aim for the bifurcation up here. And it can be technically challenging. It often requires lowering the hilar plate. But for an experienced, hepatobiliary surgeon, this is something we do a lot during liver resections, during biliary reconstructions. So it's certainly something in our wheelhouse, but a necessary step in going to an area where you don't have a significant amount of inflammation. And this is fresh planes in this area. And oh, by the way, this is also likely the area that has the most robust blood supply. This is where the right hepatic artery will start to give off the blood supply to the bile duct, and then start going inferiorly at that 3 and 9 o'clock position. So this is the most likely area where you're not going to have ischemia. And the other benefit of going higher and avoiding sometimes, I'll get into in a second, is you have a lot more leniency in creating how large of an anastomosis you want. You're not just chained to the size of the bile duct itself. So, when I am doing the anastomosis itself, and when I am opening up the bile duct or exploring the bile duct, just like I need to cut back or avoid any cauterized or damaged tissue, well, I want to make sure I'm not using any cautery to control bleeding at the bile ducts. And anyone who has done this before and cut open a bile duct, whether on purpose or on accident, has seen that it can often have a very robust bleeding. There's arterial pumpers at that 3 o'clock and 9 o'clock position. You don't want to just, and cauterize those areas, because that's an area often you're going to be doing an anastomosis on. So I'll take a very fine suture, maybe a 5-0 or a 6-0 suture, and control the bleeding with the suture, taking small bites in order to reduce any ischemia, but just to control the bleeding at the cut edge itself. For the anastomosis and for those vascular sutures, I'm going to avoid permanent sutures. And that's something that we probably all know, but is something that bears repeating, is that if you put a permanent suture in the bile duct, it can be there and act as a nidus for stone formation. So even though the gallbladder is out, you don't want to be responsible for this patient now having primary bile stones in their bile duct. And so that's one way that you can reduce that and minimize that. I think that the best and most robust repairs are often side-to-side anastomoses, not an end-to-side where you bring up a roux limb of jejunum and you take the cut end of the end of the bile duct and you plug it in to the jejunum. And the reason for that is, for a couple of reasons. One, sometimes you're very limited by the size of the bile duct. I mean, how big is the bile duct going to be if they didn't have choledochal lithiasis or some other pathology that would cause it to be big? It might only be 3 millimeters, 4 millimeters in size. And that would be potentially a normal size caliber bile duct. And it's can be challenging to do a good anastomosis of 3 or 4 millimeters, but also the rate that it will stricture down is going to be higher. And so if you do a side-to-side anastomosis, like in this picture, this is the bifurcation right here. So maybe there is an injury right here, or maybe the injury occurred farther down, but it was one of those class 2 injuries with a lot of clips everywhere, and you don't want to cause more harm and completely encircle the bile duct. You want to go to a fresh area higher, or maybe you notice that there was a vascular injury as well, and so you're worried that this far away from the blood supply may be relatively ischemic, and you don't want to go more inferior and do an anastomosis there. So you go higher and you lower the hilar plate, and you can, if we remember our anatomy, the left hepatic duct has a much larger extrahepatic component. So you can see if this is the bifurcation here, the right hepatic duct might only have a centimeter or so until it dives into the liver itself. Whereas the left hepatic duct will travel outside of the liver for a longer course. You can open up the left hepatic duct. You can even make maybe a little smiley face here and make a curvilinear incision and go along both the right and hepatic duct. Maybe you'll notice, and you got a good roadmap beforehand, and there's not a bifurcation, but maybe there's a trifurcation of the hepatic duct here. And there's, the right posterior is coming off here, and the right anterior is actually coming off before it. And so you might actually have to open up in several areas. And then you bring your roux limb up of your jejunum. And now, whereas before, if you would have been forcing the issue and you would have been creating an anastomosis just to the end of the bile duct, and now you've only opened up a 3 millimeter opening of that jejunum and try to force an anastomosis to that, now this is completely different. This is maybe 2 centimeters open of an opening. And I can tell you from experience and from the literature that the odds that this is going to stricture down and the odds that this is going to fail and need interventional radiology for stents or need a secondary operation is significantly smaller. And because you're dealing with a larger anastomosis and you're dealing with a better vascularized anastomosis. And so for those reasons, I think a lot of experienced biliary surgeons will do these anastomoses up closer at the bifurcation in order to get a fresh plane, in order to have a wider anastomosis, and in order to avoid any areas of ischemia. I talked about a roux limb of jejunum, and that's the standard. It's possible to use the duodenum and perform a hepaticojejunostomy. And I've done that in some situations, but not for very high anastomoses. It's usually been situations where you can completely cocarize, you have a good floppy duodenum, so you're not worried about tension. And almost all of the ones that I've done this for have been ones where I've been called in at the time of the index operation, or the patient has been sent to me on the same day as their laparoscopic cholecystectomy. And I think you have a little bit more leeway because oftentimes those injuries, you can do a lower anastomosis. This is not an E4 type of injury that I'm going to repair using the duodenum, but maybe an E1, maybe an E2 type of injury. Stenting is very individualized. It's not necessary to put a stent in there. It does not reduce the rate of stricture. It does not reduce the rate of leak. But if that's something, but there are still lots of surgeons who do that and have excellent results with that. So it's not anything that you shouldn't do, but it's not something you have to do. And then, here's just a quick, study that looked at, I want to say 163 different bile duct injuries. And these are broken down in class by the Stewart Way injury class. And it compares outcomes of who did the bile duct repair. Was it the primary surgeon who did the bile duct repair? They recognized the injury and they repaired it themselves. Or was it an advanced biliary surgeon who did the repair, and what were their outcomes? And it compared the outcomes between the two. And you can see that not only the total success rate of primary surgeons, and it shows a success rate of only 13% out of 163. And that's even with IR. Sometimes IR got involved, but there was a failure rate where they had to refer almost 80% of the time. Compare that to the biliary surgeons totals, where 91% of their repairs were successful, and only 5% even needed a second repair. So this isn't the biliary surgeons who had success on their 8th or 9th surgery. No, this is first surgery. And this is true not just for the totals and not just for the difficult ones, the class 4 and class 3, but even class 1. The success rate was only 43% of the primary surgeons. Now, unfortunately, not huge numbers for the biliary surgeons, because class 1s aren't getting referred to biliaries, even though the rate of failure is over half. A lot of these are not getting referred to biliary surgeons. But class 1 and class 2, 35 total, a 100% success rate. And once you deviate from class 1, you're looking at low teens, 11, 12% success rate, 0 success rate with class 4 when the primary surgeon does it. So I think that there really is an argument to be said that all of these should be, they don't always have to be sent to another hospital. Maybe you have someone with that expertise in your hospital. And I've been called in to my own hospital many times by acute care surgeons, by busy, good, experienced private practice surgeons. Any of the hospitals in the area that I have privileges in, I've been called in, to assist. And sometimes they call me in and they say, I'm just worried about this, and it isn't an injury. And that's okay. I would rather get called in more often than not get called in, only one time, right? When it could have been 100% success, but they were afraid that maybe they would get yelled at or looked down upon. And now this patient only has a less than 50-50 chance of having a successful operation on their first go.
So jump in for 1 second. Gosh, I would even think it would be unacceptable not to send such a patient to a hepatobiliary surgeon or transplant surgeon, somebody who does that every day, not due to anything other than the potential circumstances. As a surgeon, you've already failed that patient once with a catastrophic injury, and not sending them to somebody who has the expertise of repairing that, I think, would be a second failure. Is that even acceptable?
I think that, there's a lot of different reasons why people do and do not refer to other surgeons. And so it's hard to, we're maybe diving into the psyche of surgeons as much as the expertise of surgeons now, which certainly is above my pay grade. But I think that, absolutely err on the side of caution. And, this isn't true, in my opinion. I don't think this is true just for biliary injuries. I think this is true for any major complication. Oftentimes, you're just not in the right state of mind to fix this complication, because so many things are going through your head. I can tell you, if I was doing a lap chole and I caused a biliary injury, even though I have experience and I fix these, I would call for help. I would call one of my partners in, and I might not send them to a totally different hospital, but I would certainly call in another surgeon to assist me with the case, and
that's incredible.
Down and yeah.
That's incredibly insightful, Jesse, and thank you for sharing that, because I have seen at our own institution people talk about, well, so and so always calls for help. Well, I think calling for help in a situation when you're not sure of that particular situation, or yourself or your skills, is a sign of good judgment, but not a sign of weakness. Well, thank you guys very much for your participation. Really looking forward to the third installment of this. It's going to be a very nice series when all put together, and hopefully as many people as possible can take advantage of it. And it's available free of charge on the National Surgery app.